Well, welcome everyone. I know people are still, yes, it looks okay. Yes, I think so. People are still joining in, but while you're all connecting your audio, we'll do the part that you don't want to hear about, which is me introducing. I am so pleased today to introduce Dr. Daisy Singla. She'll be talking in just a few minutes, and I'll give her bio in just a few minutes. But before I do, I want to acknowledge that at least at the Women's Health Research Cluster, the majority of us live, work, and play and participate in a community on the unceded, ceded, and traditional territories of 203 First Nations, along with 38 Métis chartered communities, each of which possess their own unique traditions and history here on this land that we now refer to as British Columbia. We acknowledge the importance of the Truth and Reconciliation Commission of Canada's call to action, the United Nations Declaration on the Rights of Indigenous Peoples, and the BC Declaration on the Rights of Indigenous Peoples Act. In all of our work, we are committed to ensuring Indigenous women's rights to health and safety and the equal opportunity to participate in a manner that recognizes and respects Indigenous cultures and traditions. Today, I am not joining you from Vancouver, but Vancouver is part of the unceded homelands of the Coast Salish peoples, the Musqueam, Squamish, and Tsleil-Waututh First Nation. Today, I'm joining you from Toronto, which is covered under the Treaty Number 13 from 1805, I think. It was a treaty that was signed with the Mississaugas of the Credit, as they were known at the time. And with that, I just want to say, this is brought to you by the Women's Health Research Cluster. We have over 400 members across 18 countries. We have a number of events. There is a conference going on right now on how hormonal contraceptives affect brain health. Please join it if you haven't already. Trainees that are joining us, there's a number of trainee travel awards. We have a really good acceptance rate, like might actually have 3 digits. So please look out for them when you see that. A number of collaborations. And if you like what you do, please do support us. And with that, I'm going to stop sharing my screen so that our speaker can share her screen. And while she's doing that, I will read out her bio, which is on my phone. So apologies, I'm going to have to read it off my phone. Dr. Daisy Singla is a clinical psychologist by training and an associate professor in the Department of Psychiatry at the University of Toronto. And in July 2022, she became the first woman mind scientist at the Center for Addiction and Mental Health, which is where I am currently located. I'm so excited and delighted that she agreed to speak to our group. To date, Dr. Singla has led or contributed to large clinical trials focused on improving child growth, health, and development, as well as reducing maternal depression worldwide. She has collaborated with global mental health leaders and local NGOs in rural Uganda, Kenya, Bangladesh, Nepal, India, and Pakistan. Holy, talk about global. She now brings these innovative lessons to the United States and Canada. And in 2022, Dr. Singla was named a fellow for the Association for Psychological Science, which is amazing. And in short, Dr. Singla aspires to increase access to evidence-based psychological treatments to enrich the lives of all women, their families, and their children. And as you all know, I like to give out a fun fact. And Dr. Singla has a pretty great dream job, but her other dream job is to be a surfer. So I want to know where she surfed. I want photographs. I need evidence. I have never been able to do any of that, but I'd love to learn. So maybe we can take a trip to Hawaii or something and learn together. Or you can teach me. Sorry, I know you know. Thank you so much for doing this, Dr. Singla.
Thanks so much for having me, Lisa, and to your group for orienting me. It's lovely to be here, here as in not just on Zoom, but here with your group and the participants in the room. You know, I know you have the chance to ask questions at the end of my presentation, but if at any point you require clarification, feel free to put your comments or questions or suggestions in the chat, and I'll be sure to get to it when I can. So thanks everyone for joining today. It's a pleasure to be here, and I'm here to talk about some of the treatments that we offer for perinatal women, that's pregnant and postpartum women, and some of the work that I've done abroad, but also bringing those lessons learned to our local context here in Canada and also the US. So as Lisa has mentioned, I am a clinical psychologist by training, but I'm very much a global mental health researcher at heart. I'm not going to go into my full autobiography, but simply to say that I was born and raised in Canada. I then spent most of the decade of 2010 to 2020 abroad in some of the countries that Lisa has mentioned, and really having the privilege to work along local NGOs as well as global NGOs with a very key focus in mind, and that focus being to improve access to evidence-based psychotherapies for very common conditions such as depression, anxiety, and trauma-related disorders. During my internship, our one-year residency as clinical psychologist, I had a pretty full patient caseload, and I came to realize that much of the issues related to access were very relevant to home. And so I'm going to be taking you through that journey with a particular focus on psychological treatments, overlapping with terms like psychotherapy or talk therapies as well. So as you may or may not know, psychological treatments are actually amongst the most effective interventions in medicine and recommended as the first line of treatment to address this hugely significant and growing burden of depression and anxiety and stress-related disorders worldwide. In low and middle income countries, and I've worked, as Lisa has mentioned, in sub-Saharan Africa and continue to work in South Asia, 1 in 20 individuals may have access to minimally adequate treatments for depression. And yet we're not doing that much better in high-income countries such as Canada and the US. 1 in 5 at best have access to minimally adequate treatments. That includes medications, and even fewer have access to talk therapies. So unfortunately, despite their robust effectiveness, psychological treatments remain inaccessible for the wide majority of the world's population. Perinatal women, pregnant women, and postpartum women up to 1 year post-childbirth are no exception. In fact, perinatal depression and anxiety affects 1 in every 5 women. That's 20% for those of you who know your maths. And that number is probably an underestimate, given how low reporting we actually do in our health service clinics on a regular basis. Interestingly, amongst pregnant women, the wide majority would prefer to engage in individual psychotherapy. However, there are very, very common barriers that you yourself may have encountered or know of your significant others, friends, family members to have encountered. That includes the very first and foremost cost, access to specialist care, learning how to navigate the healthcare system, and of course, for perinatal women in particular, arranging transportation and even childcare are hugely significant barriers, particularly in the postpartum phase. So one solution that I've worked on, but actually many individuals around the world are working on, many groups around the world are working on, is this construct of task sharing, meaning to train ordinary people to deliver evidence-based psychological treatments. And what do I mean by ordinary people? In this case, these are individuals who do not have a formal background or training in mental health care. These are individuals who range really, depending on the context, from health volunteers, peers, community healthcare workers, teachers, nurses, midwives. I would add doulas to that list. There's a whole number of individuals who don't have formal training or degrees in mental health care, and yet they have been able to effectively deliver talk therapies around the world. As Lisa mentioned, I have worked alongside local NGOs to implement and evaluate the integration of mental health care in both community and healthcare settings. In Uganda, I conducted my PhD thesis, which I'll be talking about in a moment, not only to improve maternal mental health, but also to improve child development. And I continue to work with an organization called Singla across India to also improve access to mental health care. And here are some of the other places that I've worked as well. But in Uganda, in Lira, Uganda, actually, which is located 352 kilometers north of the capital city of Kampala, we collaborated with a local NGO as well as local academics to deliver a parenting program in rural communities. What was unique about this parenting intervention is not just that it focused on both child health and development, as well as maternal mental health, but it was actually attended by fathers. Typically, parenting interventions are only attended by mothers, sometimes grandmothers, and often the men are not invited to attend interventions when in fact they can very much be a risk factor or a protective factor for things like child development and maternal mental health. The program was delivered by trained community members or peers, so not individuals like myself or like Lisa who have gone to school for far too long, but rather trained community members who are actually elected by that given community to deliver this 12-session group intervention. And that group intervention was also coupled by 1 to 2 home visits to ensure that individuals were given the individualized attention that they may benefit, and also use that as a problem-solving exercise. I'm going to talk to you a little bit more about the content of the program, but simply to say that it has been published in the Lancet Global Health back in 2015, 8 years ago. And so if you're interested in the program, you're welcome to refer to that manuscript. But what we really focused on, and I hope that all of you can keep this in mind as you listen to what I'm referring to, are 5 key messages. And with regards to the construct of maternal mental health, we never use jargon. Instead, based on our conversations with the community, we talked about the message of love and respect. So love and respect yourself, love and respect your spouse, and love and respect your child, which really resonated not just for the women attending the program, but also the fathers, which was hugely helpful. And so based on my work abroad, it really made me wonder, how can we reimagine mental health care in terms of who provides these effective treatments, what comprises an effective mental health intervention, where is it delivered, and how can these treatments be delivered and monitored in a way that's effective? These questions led me to another manuscript, which was published back in 2017 in the Annual Review of Clinical Psychology, which compiled all randomized control trials from low and middle income countries to look at non-specialist delivered psychological treatments. That's a mouthful, and I'll go through this in more detail, but simply to say that back in 2017, there was 27 randomized control trials from 22 countries, and that evidence base has actually almost doubled in size from low and middle income countries. And in high income countries, just for perinatal populations, we've identified almost 50 trials over the same time span. So who provides these brief talk therapies? And in a nutshell, non-specialists includes anyone who is intending to provide mental health care, but like I said, does not have that specialized professional clinical training in a field closely related to mental health. This includes community healthcare workers, peers from the same communities, nurses, midwives, teachers. In the trials that we identified, the 27 trials that I had mentioned, the majority were female, and the education level was primarily those who had received a university degree, but also a significant minority, almost 1/4, only had a primary level education. Certainly in our Uganda trial, individuals required a minimum of 8th grade education, and yet were able to demonstrate an effective intervention. That's not to say that just because non-mental health specialists can deliver these interventions, that there is no role for the mental health specialists. We are not trying to replace mental health specialists. In fact, in the trials that we had identified, mental health specialists played a number of roles, including supervising non-specialist providers, evaluating the treatments, providing referrals, ensuring safety, and often providing medication in situations where medications were required. In terms of where these treatments were delivered, again, in a nutshell, it was where it was most convenient for participants. Mind you, 2017 was pre-pandemic, And so virtual treatments at that time, even though we were using our phones arguably as much then as we are now, were not exactly as popular. Telemedicine was not exactly as popular as it is now. There were a lot of questions about digital interventions. And so with the trials that we had identified, they were essentially delivered where it was most effective and convenient and safe for patients to attend. That included schools, outdoor community settings, primary care centers, and even their homes. In terms of the how, really what we found were sort of four key ideas. The first is the train the trainer model. In many parts of the world, certainly in low and middle income countries, and certainly in places like Uganda, you may have one psychiatrist for every 10 to 20,000 people. That is simply not enough. Sorry, one psychiatrist for every 100,000 people. That is simply not enough people to deliver care. And that's where a lot of these ideas of non-specialist delivered interventions come from. So we focus on the train the trainer model because it builds capacity in the community. Again, in the Uganda trial that I mentioned, I was not the person delivering these interventions, nor were my academic colleagues. Rather, peers were the individuals who provided the intervention. They went on to train other peers to deliver this intervention, actually across 5 countries in sub-Saharan Africa. The training of these interventions lasts about 10 days, and arguably as few as 5 days. But the real learning comes from practice. Practicing, learning how to deliver sessions. It doesn't come from a workshop. It certainly does not come from a workbook or a manual, but rather having the opportunity to actually deliver the program or the intervention that is being suggested. Supervision is really, really key. Certainly for any of you who have conducted psychotherapy, and I'm sure there's a diverse group of individuals watching this, certainly for any of you who have conducted psychotherapy, I'm sure you would appreciate how important supervision is between sessions and across sessions. So supervision tends to occur on a weekly basis. And as I mentioned, digital platforms were largely lacking back in 2017 when this review was published. But as we know now, digital platforms have arguably become the norm for how treatments are delivered, even in low and middle income countries. I also want to highlight the importance of mediation. So we know that these interventions are effective. I promise I'll be giving you some more robust statistics to support that. But equally important, I think we need to examine why are these interventions effective or not effective. And one way to do that is to examine potential mediators of our effective interventions. In the case of one intervention known as the Thinking Healthy program, which was arguably one of the largest trials for maternal mental health, first conducted in Pakistan and then replicated in many other contexts. We found that increased patient activation and increased perceived support mediated the effects of a brief cognitive behavioral intervention to reduce maternal mental health, whereas mother-child interaction did not. And one of the reasons that might be is because mother-child interaction, or the interaction between the caregiver and the child, was not exactly directly targeted in that program. And so by getting at the mediators, we really have the opportunity to examine what works and how can we improve our interventions by targeting specific ingredients. So the question that I always get from individuals is, okay, great, you've identified the various elements, you've identified a number of trials, but do these things actually work? So we conducted a meta-analysis, again, the same paper that I had mentioned back, that was published back in 2017. And to my pleasant surprise, the interventions actually demonstrated a medium effect size. And when you look at specialist delivered interventions in the West, actually these effect sizes are pretty comparable to those trials. And yet there's been very few studies that have actually compared specialist delivered interventions to non-specialist delivered interventions. The other question that I get is, okay, fine, they work over there, but what about here at home? And what about for perinatal populations? And so we replicated a very similar study, only focusing on high-income countries and focusing primarily on perinatal populations, looking at, well, first of all, are there non-specialists delivering these interventions? And indeed, we identified 45 trials just on perinatal populations, and again, found good effect sizes for conditions such as depression and anxiety. I think what's really important as we drill down on the who, where, what, how, and why in perinatal populations is focusing on who could be the potential non-specialist provider. And in most of these trials, again, this search was conducted pre-pandemic, most of the non-specialist providers fell into two categories of midwives and nurses. The majority were conducted face-to-face. And interestingly, when we asked authors or looked at the secondary data as to why that particular cadre was selected, similar to low and middle income countries, it's because those were the cadres who were patient facing. Those were the ones who were already in those existing healthcare and community settings. And so I thought to myself, particularly because I had graduated and I hadn't had the foresight to actually look for a job while I was in graduate school, I wondered to myself whether these brief evidence-based psychological treatments could potentially be reverse engineered to address perinatal mental health here at home being Canada, as well as some parts of the US, and asking myself, well, who could deliver these treatments in Canada and the US in situations where it was most patient-centered for the perinatal populations that we serve. And that led to the development, but also the funding of the Summit trial. So the Summit stands for Scaling Up Maternal Mental Health Care by Increasing Access to Treatment. And it is an ongoing trial, and I'll talk about it in a little more detail in a moment. It's funded by an organization called PCORI. So for those of you looking to conduct your own large intervention trials, we've had really good experience with PCORI. Yes, they are based out of the US, and so you will need US partners in order to receive funding from them. But interestingly, similar to what we do in global mental health, they're really focused on a few key similarities, including improving the health and well-being of patients and their families, but also really focusing on real-world settings. So pragmatic settings, conducting research where clinical services are actually delivered, and also focusing on sustainability rather than research trials just being research trials in and of themselves. The PIs include myself, Dr. Samantha Meltzer-Brody, who's my co-PI and partner in crime from the University of North Carolina, Richard Silver, who is an obstetrician and leads North Shore Health System, which is located in Chicago and Evanston. Simone Bigot, who some of you may know, especially if you're located in Toronto, who serves as psychiatrist in chief at Women's College Hospital, and Cindy Lee Dennis, who is a nurse by training, but also an epidemiologist and professor of nursing at the University of Toronto. So it's an extremely interdisciplinary leadership team, but important to say that we're not just a bunch of academics trying to resolve this issue. The team is actually 140 people and growing, and it involves everyone from investigators and research staff, and most importantly, involves an extremely diverse stakeholder group. So you have academics, individuals with lived experience, a whole wide cadre of specialist and non-mental health specialist providers. And you have health administrators, you have people representing insurance companies, because we know how important those folks are, especially in the US. You have health policymakers all sitting at the same table, talking about how to improve access to mental health care within this trial context. So what is the trial and what are we asking? So, and some of these questions may be particularly relevant, as I've discussed, some of the background that I've had. So the first question that we're asking is telemedicine as effective as in-person psychotherapy? So getting at the how. The second question that we're asking is, can these non-mental health specialist providers deliver a brief psychotherapy as effectively as specialist providers? The non-specialist providers in our context being Canada and the US, healthcare settings in Canada and the US include nurses, midwives, doulas, and OTs, and really getting at the who. So this is a non-inferiority trial. We're not looking at whether one is better than the other, but really whether one is non-inferior or as effective as. And so participants, the trial is 1,226 participants is our target sample size. We are making progress, and I'm planning to share some progress updates with all of you. Individuals are randomized to one of 4 arms, and that's in-person specialist, telemedicine specialist, in-person non-specialist, and telemedicine non-specialist. The trial is being conducted in 3 hubs or 5 recruitment sites. Sorry. So we have 3 sites out of the University of Toronto. That is Mount Sinai Hospital or Sinai Health, Women's College Hospital, and St. Mike's. We also have the University of North Carolina, and as I mentioned, North Shore Health System, which is based out of the University of Toronto, out of Chicago and Evanston. The sample size is 1226. If any of you have looked up the trial's protocol or have Googled, our original sample size was actually 1368. And one of the reasons it's reduced is because we had originally accounted for a 20% dropout rate, but because the trial has been going quite well, we've actually seen less than a 10% dropout rate since the very beginning of the trial. So with the permission of our funders, as well as our DSMB and our various ethics committees, and of course, this very diverse stakeholder group, we were able to reduce our sample size from over 1,300 to a little over 1,200. Our inclusion-exclusion criteria is quite relaxed. And one of the reasons that is the case is because this is a pragmatic trial. So we want it to be as generalizable as possible. In the US, we offer the treatment in either Spanish or in English, depending on the participant's preference. And here in Canada, we are only offering it in English, despite the many languages that we speak across this country. The exclusion criteria that you see is largely because the intervention that we're using, behavioral activation, and I'll go into that in a little more detail, is not appropriate for things like, has not been shown to be effective for things like active substance use, dependence or abuse, or for individuals who are experiencing active suicidal intent, active psychosis, or mania. So I think it's fair to say that the intervention that we're offering, we're not testing whether the intervention is effective, but rather the comparisons of specialist versus non-specialist and telemedicine to in-person. This is only a fraction of our team. Some of you may recognize some of these faces in the crowd, but simply to say that the team is large and growing and represents individuals from many, many different kinds of stakeholder groups, as I mentioned before. The treatment. So we have adapted, we are using behavioral activation in this trial. Everyone gets the same 6 to 8 session individual behavioral activation. And BA is basically identifying your values in order to facilitate activities that will improve your mood and well-being. And we selected behavioral activation for 3 reasons. The first is it has a strong and growing evidence base, and in fact has been demonstrated to be as effective as longer courses of psychotherapy and medications. The second is that it's effective in treating perinatal depression and anxiety, who is obviously our target population. And thirdly, I think it's quite, at least from my perspective, especially as a clinical psychologist, one can argue that it's easy to learn. And it's been successfully implemented by a whole cadre of non-specialist providers from India to Colorado to the UK. There's been many different cadres who have learned how to successfully implement behavioral activation. I think what's interesting about what we're doing with how we developed our behavioral activation is this is a unique example of reverse engineering. So yes, behavioral activation was originally developed in the US. It was then adapted by Vikram Patel and his colleagues in a program called the Healthy Activity Program, delivered by lay counselors in Goa. Almost simultaneously, that same 8-session intervention was adapted for the delivery by peers in Colorado. And so we took both source manuals to ultimately reverse engineer what Vikram Patel and his colleagues had done in India for our participant populations, for our perinatal populations here in Canada, in the US. And the reason I'm highlighting that is because too often we take interventions from the West and apply them to other contexts. And in fact, I think there's actually really important lessons to be learned the other way around. And if you're interested in some of Sona Dimitrian's work, as well as Vikram's work, I've put some papers up on the screen here, including those published in The Lancet, as well as those in PLOS Medicine. The other thing that I'm extremely interested in, and that I mentioned before, is mediation. So we already know behavioral activation is an effective intervention and a first line of treatment for things like depression and anxiety, but we have an opportunity in Summit to examine what are some of the key ingredients to influence not just clinical outcomes, but we're also conducting home visits to examine things like child mental development, parenting practices such as psychosocial stimulation and breastfeeding, to see if we're influencing those, as well as maternal mental health. So the exciting stuff, the progress. Simply to say that we started the treatment back in January 2020, pre-pandemic. Certainly I didn't have knowledge of the pandemic at that point. We recruited our first participant the first week of January. As you all know, the pandemic had hit in March 2020. To my surprise, I've never seen healthcare systems and REBs and DSMBs move so quickly as I had in that month. So we transitioned everything quite swiftly to a virtual system. We've achieved many high targets of recruitment. Every single participant who is eligible and enrolled has access to psychotherapy. It's not that someone is sitting on a wait list to receive psychotherapy. So I think that's one of the enticing things about this trial. A little bit later in 2021, we then received approvals to resume in-person sessions. And I'll come back to why we decided to actually examine in-person psychotherapy in a moment. And as a result of our successful recruitment, we actually had to slow down. Recruitment because we couldn't use up all of our telemedicine slots. In August 2021, we officially resumed recruitment for all in-person cases across all 5 recruitment sites. Then in December 2021, you may remember the Omicron variant, and we had to again pause recruitment, at least for in-person, until that resolved. Earlier, about a year ago, we started our home visits, and we received approval to reduce our final sample size from that 1,300 number to 1,226. We also received a 6-month no-cost extension. And today we have recruited over 1,000 participants. We continue to monitor our recruitment, retention, ethnicity, and other important indicators. We're actually in our final year of recruitment, and we plan for dissemination and scale up, which I'll talk about in more detail. So one of the questions that we as a study team debated is whether we even want to resume in-person therapy. Some individuals felt quite strongly that in-person psychotherapy was an old school concept, something that's no longer relevant, especially in the midst of a pandemic. And we conducted bioethicists as well. And it became very clear that we were at a historic point of mental health care and how mental health care could be delivered. A historic point because we may never be able to compare in-person psychotherapy to telemedicine psychotherapy, especially as we move on. And this is especially important for perinatal populations because there may be some people who actually may benefit more from in-person psychotherapy than telemedicine psychotherapy. And the reason I'm mentioning that is because we know that domestic violence has increased significantly over the pandemic, particularly for perinatal populations. We also know that individuals may not have privacy or a safe space at home to conduct telemedicine delivered psychotherapy sessions. And so we're really excited that in a trial of this size of over 1,200 participants, we'll be able to get at some of those questions of what works for whom and whether there's certain participants who may benefit more from one modality versus another. So to date, if you're interested, you can visit our website, and these statistics are updated probably on a daily basis. So we have, as I mentioned, we're over 1,000 participants. What's really exciting about this trial is that in most psychotherapy trials, we don't see a lot of racial and ethnic diversity, whereas we've made it a point in Summit not just to recruit Spanish and English-speaking participants, but to recruit ethnically diverse populations. And also to examine satisfaction across these various groups. So what we're seeing is very high satisfaction rates, which I'll get to in a moment, but also high retention rates of over 90% at 3, 6, and 12-month follow-ups. In terms of client satisfaction, we see that participants rate their experience as being between mostly satisfied and very satisfied. And when we ask what participants like, they report that they like having a provider who shows empathy, and also the treatment itself, behavioral activation, the tools and activities that it offers. When we ask participants what did they not like or what would they like to change, they report that they wouldn't change anything, or that they would like more sessions, are sort of the two primary answers when we ask them this in an open-ended fashion. Importantly, and especially because we have such a diverse, ethnically diverse sample, we also wanted to look at client satisfaction across various ethnic groups. And it's a lot of reassurance to see that there is no significant difference between various ethnic groups in terms of their reported self-satisfaction with the treatment. And when we looked at this, when we compared whites to BIPOC participants, we also found no difference in their satisfaction scores. And these results were recently published in the Journal of Clinical and Consulting Psychology. In the same manuscript, we also developed this rubric to facilitating culturally sensitive psychotherapy. So with the permission of Ibrahim, we adapted his becoming an anti-racist model for becoming a culturally sensitive treatment provider, going from what he entitled a fear zone to the learning zone to the growth zone to ultimately facilitate culturally sensitive psychotherapy. I don't think this is specific to psychotherapy. In fact, for those of you who are in other fields, beyond mental health care, I think this is relevant. And the quotes or phrases that you see are those from the various stakeholders that we interviewed, namely non-specialist providers and specialist providers, as well as supervisors, to see how we could move from the fear zone to the growth zone. A bit about behavioral activation. So the satisfaction scores speak to this quantitatively, but we also conduct qualitative interviews with a whole range of stakeholders, including the perinatal women themselves, as well as the treatment providers, the clinical supervisors, and other stakeholders. I'm not going to read all three of these out, but simply to say that the experience of our participants across settings has been quite positive, varying with participants reporting on positive aspects such as self-reflection, giving them a different perspective, as well as having someone to talk to. And this was particularly relevant during the pandemic. So in terms of timelines, and this is something that I certainly keep track of, recruitment is going to continue until October. The treatment will continue until about March. And we're really excited about getting to our primary outcomes. This has been no small task, the Summit trial. And to my knowledge, it will be amongst the largest task sharing trials in the world, if not amongst the largest psychotherapy trials in the world. And so we have a lot to do before then, but our primary data or primary manuscripts, we're really hoping will be available. We'll start to prepare those a year from now. So in terms of next steps, we're continuing recruitment. We are continuing our home visits, and that's really to assess child mental development and some of those parenting practices. We are conducting a cost evaluation study, as well as involving policymakers to ensure that the trial is sustained, that the intervention is sustained beyond the trial setting. And I'm happy to take any questions if you have them. Thanks so much.
Well, thank you so much, Dr. Singla. You guys all know, hopefully, how hard it is to do these kinds of virtual talks. So please give a little clapping emoji or a happy emoji, no sad emojis. Thank you so much. I can see them. I don't know whether you got to see them. Daisy, there you go. I was busy tweeting away, and really, really exciting, actually. I think this is probably the first time I've heard you give a long talk on what you do, and it's just inspiring. I'm sure all of us had that same feeling. If anybody has any questions, feel free to put them in the chat. I can ask them for you, or please feel free to unmute yourself and ask the question. And I will start doing it. I'm always, I'm supposed to wait a long time, because if you wait a long time, someone will put up their hand and ask a question. But if not, I shall go there. So I think this is like super fascinating for a lot of reasons. I mean, you've got so much to mine from your data, right? The virtual versus the in-person, it was so like learning from different cultures, and like sort of, I think you called it even reverse engineering, which, we do have such a superiority complex in Western countries of how we do things, and that must be the best way. But of course, learning from other cultures is really, really important. And I was just so inspired by the 50% of the BIPOC individuals you've got. So I want to ask questions about that. I really like the whole anti-racism paper. I want to go read it. But I'm going to ask you this question first. So are you assessing, like in my thinking, without getting too personal, thinking about my own talk therapy sessions that I've had, some people I really connect with and some people I don't connect with. And obviously I personally feel like I get more from the people I connect with. So do you assess that as part of, I'm sure you must, and how do you do that? Sort of like that connection. I'm not thinking about the mother-child dyad, but almost like the non-specialist to patient dyad.
Yeah. I think what you're referring to, Lisa, and correct me if I'm wrong, is the connection between the treatment provider or therapist and the patient.
Yes, exactly.
So psychological treatment jargon, we call that therapeutic alliance. And there's a really great tool to measure that called the working alliance inventory. Mm-hmm. And so we are assessing that obviously once someone has enrolled in treatment, after each session, but also at the end of their sessions at 3 months post randomization.
Yeah. Great, because I mean that to me is going to be this is just somebody that doesn't work in the field at all, thinking that that's just going to be one of the biggest mediators that you see. But I also thought it was really cute that when you asked, is there anything that you would like to see changed? It was more about more sessions, which I mean, as it just, I think, also speaks to the satisfaction, right? That is one of the number one things that people were interested in. So how did you make it? Oh, here's a question. Yay. See, I thought if I talk long enough, so it's not all about my questions. How is behavioral activation different from psychoeducation and even in-person breastfeeding instructions? And actually, I wrote that down as a question. What is behavioral activation?
Yeah, I went through that very, very quickly. So the mantra of behavioral activation is, in order to feel differently, you got to do differently, which sounds slightly off when you're talking to perinatal women, but it's really about identifying one's values. There's a whole exercise that one goes through, identifying one's values, and then examining what are the activities that take place in your everyday life, what's working for you and what's not working for you. So the difference between something like psychoeducation, where you're just getting, where you're getting a lot of important information about the condition, about whatever mental health condition you have, about the impact, is that with psychological treatments, you're also given tools for how to address some of those negative spirals that you sometimes end up in. And that's really, really critical, whether it's changing your thoughts, whether it's changing your behaviors. These are things that one actually has some autonomy over, whereas one cannot just magically change their emotions. And once we recognize the link between behavior and emotion, we feel, one of the things that patients report are that they feel a lot more control or autonomy over their lives. And so the biggest difference I would say, between psychoeducation and behavioral activation, but really any psychotherapy, is that you're actually equipped with tools so that when you run into that situation where you're feeling really guilty, you can't interact with your baby, you don't want to see anyone, you're not eating, you recognize that those are cues, and sometimes and acting the opposite or engaging in behaviors that are more productive allow for you to get out of that downward spiral.
Great. Thank you. That was really helpful. How did you achieve 50% BIPOC participation?
Yeah, it's a great question, Lisa. I would say it's partly luck and partly purpose. So first of all, we're recruiting in very, very diverse settings. Toronto, Chicago, and Chapel Hill. These are all health systems that tend to these are all cities that allow for very diverse populations. But I think what's really important is we're not just recruiting from downtown Toronto hospitals, because then we would just get the usual. What's really important is that we are collaborating with local NGOs, with local community groups, and inviting them to send over their referrals, so long as a participant has an MD that we can go back to in case they need to be referred for further services. So I think it's those partnerships, similar to our stakeholder engagement approach, which has served us widely and has served a much richer, diverse population.
Yeah, I mean, it's great that you already published on this. I'm sure there's more information too in there, but I think it's going to be one of those great articles that we can point to when people say, "Oh, we tried and we couldn't get the population." I mean, obviously, if you make a concerted effort, it's very, very possible. You have some questions in the chat, Susan, and did you want to unmute yourself, or do you want me to ask your question, Susan?
Hi, sure. Thanks very much. That was terrific talk and really exciting work. We're doing a qualitative study now on perinatal mental health needs, and my colleague Anna is online as well. which involves interview with or without video if they so choose, and the results will be posted hopefully sometime next year online on our healthexperiences.ca website. But very curious about how you are recruiting, and I joined a bit late, so I'm sorry if I missed it, but just we've had some interesting experiences recruiting online, but it sounds like you may have answered my question already. If you're going through partners and having people actually just do direct referrals rather than recruiting online, for instance, or through other Facebook groups or other sources of social media.
Yeah, absolutely. So we had
Thanks.
explored that option, Susan, and maybe I can just share my screen so you can see the eligibility criteria while I talk about.
There it is.
Are you okay seeing that?
Yeah.
Okay, great.
Thanks so much. Yeah.
And what I had mentioned with regards to this was the exclusion criteria is really because there is not we had to ensure that the intervention we were offering was appropriate for the populations that we were offering this to. So the exclusion criteria is simply because behavioral activation, the treatment that we are using, it has not been supported for things like suicide, active suicidal intent, psychosis or mania, or even things like substance use, abuse, or dependence. But with regards to recruitment, we had explored the online, recruiting from Facebook groups and that whatnot. But actually, our REB said no. They simply said that you can't do this, and their reasons were that how can you, knowing that we were essentially offering free psychotherapy, how would we pick and choose between one participant and another? They were worried about the influx of participants that we would get. They also wondered about how to verify if someone is actually who they are meant to be. So there was a real emphasis on focusing on healthcare systems and recruiting within the healthcare system and external referral clinics, rather than social media platforms. And I can't say that one would have worked out better than the other. So far, we haven't run into recruitment issues. But I think that it's been really, really helpful for us to actually develop those partnerships with our referral pathways, and also for participants to ensure that participants have family docs in the event that they require additional referrals or specialized care after they go through our treatment. So I think
Thanks.
it's down to partnerships.
Susan, did you ask that question again? This is not my field, but did you ask that question because you're getting some maybe unwanted participants in your online recruitment?
We did get several, actually hundreds. But the big limitation in the approach that you've adopted, which is totally legitimate and I understand it, is that, we know that a very small proportion of women who need help are actually in care and have access to care. So we don't worry so much about people having sort of a defined diagnosis, but they can self-refer because their experience actually matters to us rather than their diagnosis. And I guess I just curious because the fact that so many people don't have access, and this is what we hear over and over and over again in our interviews, that, I think it's a massive limitation to exclude so many people with that and not see that part of the population that doesn't have access to care. In terms of
access to care, Susan, are you referring to a family doctor?
Any sort of care. I mean, we have so many people without family physicians in Quebec in particular, but in other provinces as well. So, and in Ontario too. So anyway, it's just a big challenge. I'm not saying it's right or wrong.
Yeah, no, yeah,
different.
They're different. Yeah. They're really different. No, I think it's also sad that I have heard through our IT people that often the internet trolls that exist like to target women's studies and women's health talk. So it's kind of sad. And children are the other one that they.
Yeah,
but I think
thank you.
Yeah, thanks, Susan. I'm saying it wrong, and I am going to please tell me how to pronounce your first name.
Oh, good. You would pronounce it Jacinthe.
Jacinthe.
Yes. I popped in a question more around mentoring in the chat, but I'm happy to see that there's other sample size question other than mine. I am currently kind of drafting my thesis proposal, and I'm looking to study perinatal loss and kind of the experience of return to work productivity, labor force, participation outcomes. And a strong concern that we have is around sample size and demonstrating the feasibility of the project, given that it's a little bit more of a quantitative approach. So I was wondering if you have any tips in how you address that in your proposal or your funding request. The approach that I'm considering now is kind of partnering up with a market research panel to kind of field this survey.
Yeah, I think it's such an important area of research, and I can see why there may be some reductions in sample size when we would expect the opposite, given how common perinatal loss is. I think partnering with clinics and centers that see these kinds of participants will be really, really important. The partnerships have just gone such a long way for us. And I should clarify on the last point that there have been exceptions made for some participants who do not have family doctors. But I think that it's really, really key to find out, well, where are these participants going? And where do they usually end up for you to hone in on that? Because I think individual ads only go so far. And if you can link up with community healthcare and even community groups that work with these participants, it will go a really long way. I'm not sure if I answered your question.
I'd also, this comes from someone who's mostly an animal researcher, so you can just choose to ignore my rant. But I think it's interesting, the whole sample size question. I think there's and again, you can, choose to ignore me, but I think that there's an overemphasis sometimes on it. And is that going to stop the work from happening? I mean, we know it's really, really crucial to have this work. We know there are very few studies in women's health in general. And so if we're getting asked these questions about, oh, well, you'll never get the sample size, well, you'll never be able to do this study, right? And so, and also the other thing that I don't like is when people say, I don't have the power to look, at like whatever, like sex differences or gender differences or whatever. How do you know you don't have the power until you actually look? Because if your effect is reversed, we have a really, really strong effect, your sample size is going to go a really long way. So I think sometimes it's okay to push back a little bit.
Yeah, I would agree with that wholeheartedly. Absolutely. And also, even if you don't have the sample size just yet, to Lisa's point, if you find an effect, even with a smaller sample size, I think that makes for a really compelling case for future funding.
Yeah, exactly. Call it a pilot study then. Well, thank you again. We're got 2 minutes left, so I will give us all 1 minute back in our day, because by the time I end up with my conclusions, but I just want to thank Dr. Singla again. That was really amazing. I learned a lot, and I think the work you're doing is really, really fabulous, and I can't wait to hear more about it. And I'm so glad that I'm at CAMH so I can hear more about it personally before everyone else does. I shouldn't say that. Thank you so much again for your time.
Yeah, thanks again for having me, Lisa.
Our pleasure.